Welcome to Doctors at Work. My name's Matt Daniel, and this podcast is about doctors' careers. It's part of my mission to help other doctors create successful and meaningful careers. Today, we're talking about how we can build better connections. Mick Connors and I discussed the importance of interpersonal connections at work. Our careers are busier than ever, but somewhere along the lines, we have lost the deep connections that we used to have with colleagues and patients too. Instead of focusing on the person in front of us, we're focused on processes, electronic systems and targets. Now, technological advances certainly are useful. We just need to remember that human relationships matter too. The structures that fostered those connections 20 years ago in our careers may no longer exist, and it is up to us to make sure that we continue to build those connections in the modern technological world. Approaching interactions with humility, respect, and patient focus helps, as does an open mindset focused on growth. Welcome, Mick. Tell me a little bit about yourself.
Yeah, thanks for the invitation. I'm a pediatric emergency physician by training, but really got into medicine based on a brother who passed away before I was born. So I kind of grew up with my mom's stories about healthcare and those kind of things. So pediatric cancer was what I thought my specialty would be until I got a little too close to that in my training and was like, hey, I need to go in a different direction. But so interestingly enough, I guess it's been a good marriage for me because pediatric emergency medicine has allowed me to do a lot of different things in my career, not only clinically, but administratively, business-wise, entrepreneur, innovation. So I've done emergency medicine, I've done pediatric sedation, I've done hospital administration, I've started a tech company, I've done a little bit of everything, but kind of the core theme is how do you get better care for kids? So pediatrics and that has always been my passion, although you're able to jump around these days and do a little different things and kind of make an impact, kind of how it meets your needs and meets hopefully those of the patient's needs as well.
And what's a great example of a varied career that all hangs around a common theme, but that is kind of approached from many different angles. Great example. So today we're talking about the importance of relationships at work. So tell me, why are relationships at work important?
Yeah, I think I've been at this for 30 years and it's really been quite the evolution. When I started in the emergency department, we knew, or even in training in Cincinnati, we knew all the local pediatricians that came and rounded on their patients. They taught us their perspective. They taught us about their patients, what they knew about them, really impacted our care delivery, how we ordered things, how we followed up with them. And then certainly we had our specialty attending physicians around as well. We had a medical staff lounge, we had interactions, we had lunches where we learned, we had all those kind of things where we sat together, and maybe our pagers would go off now and then, but for the most part, there weren't smartphones or cell phones. And, we were all kind of interacting and learning from each other and talking about things, including the nursing staff and the registration folks. We were on paper, so it was very hard to, it was very easy to lose things. So, you pretty much had to rely on handing them off, communicating, getting feedback, and making sure things got done, and also allowed that exchange, that input between the nurse and yourself to say, you sure, doc, this is what you want to do, especially as a young resident or an intern. And the power of all those relationships really was quite powerful. So I think that was pretty interesting, to where you fast forward now 30 years and, we have the electronic medical record and we do electronic ordering, and we might know the nurses, we might not even interact with them. They carry out the orders electronically. We don't really interact. The physician, all the community pediatricians, at least over here in the US, have kind of moved off into their general practice and kind of their silo. We now have ER physicians, hospitalist physicians, specialty physicians. We, send discharge papers via fax, right? We have all these different modalities where it's more of that assembly line kind of operation of medicine without a whole lot of attachment along the way. So I think that's been a big difference. And there's very few relationships among medical staff, among our nurses that I used to value and used to be a key part of what I did as we've kind of gotten more technology, tried to move faster, try to be more efficient, but at the same time, we lose some of that personal touch as well. So I think the relationships are a big piece.
I have to say, I think that totally resonates with me, and I suspect it'll resonate with anybody who's who's been in medicine for more than 10 years or so, because we will all remember the days when we did all used to go out, and there was the mess, and we all used to have pizza together,
Yeah.
and you knew people on first name terms. You knew each other as human beings, and for me, it's very surprising. We have there's been an awful lot of strikes in the UK, and I've ended up covering some of the early career doctor shift on the strikes, and I was scandalized by how people interact with each other, as in um, yeah, I mean, I'm going to say I've been bullied. Yeah.
Yeah.
So, yeah, honestly, I've been bullied, and I'm a 50-year-old, white male consultant, and I've been bullied, sort
Yeah.
of, when I was in that role of a frontline doctor, and yeah, and actually, that is the correct word to describe it,
Yeah.
and just no relationship at all. So, um,
Yeah, the doctor on doctor bullying relationships has really kind of taken a back seat, unfortunately. We'll consult surgeons in the emergency department, and they'll never come and talk to us about the patient. They'll say, if you call them, they're like, "Why are you calling me? Just read my note." Like, it's like, hey, what happened to that interaction of my perspective, your perspective? Maybe the truth somewhere in the middle. I think we're losing some of those connections that are so valuable. And I think it's a reason we burn out, right? If we're just automatons and we have our own silo and we live in that one place, and our reaction to someone who disagrees with us is to shame them or bully them or to not really listen to understand their perspective, we all lose, right? Patients, on and on, from patients to providers to clinicians to whatever it is. Without those relationships in between, there's a lot in those relationships that drive quality, best practice, and making sure we're on the right page and everybody's aligned, that I think we're missing out on.
What's the relationship between good staff relationships and patient care?
Yeah, well, I think, I do locums. I told you I do travel doctoring over here. So I go to different places, but you can pretty much pick up pretty quickly a good relationship with your nursing staff in that respect, and that ability of a trained nursing staff and experience, which is becoming more rare, that they'll speak up, they'll bring patients to you. They'll say, "Hey, check out this kid, he's sick," or, those kind of things. And that interaction where they feel comfortable saying things to the physician, I think has become more distant. And physicians being more receptive to the other folks on the team. Like, how do we build that team leadership? We all know we're super busy. We all know we've added, quote unquote layers of staffing, right? But at the end of the day, kind of the team has gotten bigger, but we operate less like a team, right? At the same time, which I think is where some of that breaking point is to what you describe. If a medical assistant or a nurse or a physician can't question or can't ask or can't feel comfortable in some kind of relationship, it's tough. And it's the same for patients. As an ER physician, my job is to make a relationship within a few minutes, so that they trust me and can feel they are comforted. So finding a way to do that is kind of the skill of emergency medicine. But I think even more, we have to find that among our colleagues and our staff, whether we're surgeons, physicians, nurse practitioners, nurses, those kind of things. Kind of that mutual respect and relationship is really needed.
So how do you, because you travel a lot, and all the time, I'm guessing you're forming new relationships with patients and with colleagues, and that really matters. So what would be your tips for somebody who really wanted to build really good relationships quickly?
Yeah, I think it comes down, just like probably we've all learned as a physician, it starts with humility, right? And it starts with listening, and it starts with being open to other people's ideas. I think that's probably the other thing I've learned the most about traveling is when you train in one place and you train in one specialty and you become super specialized, you kind of get these blinders on that this is how we do things, right? Or this is the tradition of how we've always done things. And so the beauty of traveling is you find people that think the same way, but are doing, and think they're right and think they're right on and think they're doing everything right. And you come to them and say, well, actually, in the last 5 hospitals I've done, we've done all these things a little bit differently, and we've approached them a little differently, whether it's from a workflow standpoint, whether it's from a clinical guideline, whether it's from, how we care for patients. So I think we need more of that, what I call gray, right? We all tend to be black and white, we're right or wrong, or in the US, politically we're red or we're blue, but in reality, I think what relationships really teach you, and the more experience you get, is the gray, right? Trying to find the gray in everything, realizing that you have the humility to say, maybe my way isn't the highway or the right way. Maybe there's something I can learn at each and every interaction. I think it is the most important. And I think that's the same the patients are looking for. I know myself as a patient, I don't want to walk into the doctor and say, well, this is the only way I do these things. I want them to say, well, this is my experience. And over the years, this is what's worked most of the time, or what might work, or in your situation based on everything. Oh, right. So it's to me, it's trying to drive to that. So as I travel, I try to be open with new ways, new thoughts, create those interactions, be human, be approachable, be personable. Everything that we want out of other people, we should expect out of ourselves, right?
And how does somebody move from that right or wrong way of thinking to something that's much grayer? How does that move happen?
Yeah, I think for me, it's really been an evolution probably over time. I know you do some leadership training as well, but to me, it's kind of moving from that fixed mindset that most of us in medicine are, that, this is how I've trained, this is how we do things at NYU or at Harvard or at Cincinnati. This is kind of how we do things, to more of that growth mindset where you're kind of open to, hey, how do you do something? How is it in the UK? Like, do we train the same way? Like, our outcomes the same? Like, maybe you can teach me something here today, as opposed to kind of getting stuck in that. So a lot of it's the growth mindset, and that really takes the emotional intelligence, I think, to be able to not only take, oh yes sir, yes you're right, oh yeah, what you said is right, but I don't know if I think that way, and being able to have that emotional intelligence, not get upset or angry or frustrated, even with a patient who says, hey, I really want that CAT scan. Well, let's really talk about why I don't want to do that CAT scan, or understand why you really want that CAT scan. Oh yeah, now that I talked to you, you had a child 5 years ago that had a brain tumor that was missed. Like, that's a different discussion than, hey, I just want a CAT scan because I read on Google that I CAT scan and I can educate. You know what I mean? So there's so much in the complexity of that relationship and that trust that really requires a little deeper dive than oftentimes we're willing to do, for fear probably of having something uncovered that we don't really understand or don't want to understand, or it's quicker just to move forward, right? So I think it's that growth mindset, that humility, but that emotional intelligence to sometimes recognize you might be wrong, or you might be biased, or you might have confounding variables that are leading you down the wrong path.
Yeah. And there's something there I'm hearing about people's egos and people's identity and how they see themselves as somebody who's perfect and right, and contrasting that with everyday interaction of, as you've outlined, humility and focus on what can I learn today, what there is out there, having your eyes open rather than those blinkers. And unfortunately, I think much of our training, we're specifically trained in those blinkers because there's the right way, there's this treatment, there's this guideline. So our world is full of how we should treat a particular condition, and that's fine for some conditions, but an awful lot of the world isn't like that. This is how you treat a heart attack, or this is how you treat diabetes. And that encourages us to think that everything in the world can be reduced to, this is how you should do a certain thing.
Yeah, I mean, you and I have seen, I've been around long enough that the algorithm is right a lot of the time, but a lot of people don't follow the textbook, right? They haven't read the algorithm. They have a curveball. There's something different about this particular case. Even though I did everything right, everything the same, in one patient, I do the same thing to the next patient, and for some reason it doesn't work, or it works adversely, right? So the human DNA and the human genome is just not it's not wired like an airplane or a widget, right? And then you have the emotional side, the psychiatric side, that side of medicine that adds so much, as we know, right? Even physiologically and hormonally to kind of how you respond to stress and other things. So it's just a lot more complex than anybody wants you to really believe. That it's kind of like the discussions around AI or algorithms or clinical guidelines. Yeah, those are great. Those could help. I'm not opposed to those. Like I'm happy to have that alongside me, but at the same time, there's some of that gray in there that's not going to show up on Chat GPT. That's not going to cut through the chase here of why this patient is different than the others. So as you know, I mean, in pediatrics, we don't have a lot of patients that walk in and tell us what's wrong. We have a lot that are crying and nonverbal that you're kind of sleuthing things through. And I think there is a bit of that over the course of your career. You realize that training and experience means something over and above just, the person fresh out of residency or training that is ready to roll.
So we talked a little bit about the individual healthcare professionals' mindset and, this idea of being open and being curious and humility and learning. But we started off talking about how we work in systems that in many ways work against the creation of connections. So how can we change the system, or how can we compensate for the fact that we work in a system? I mean, the system, all of those electronic things, there's stuff that's good about them, but the cost is we've lost connection. So how can we revise that, or how can we compensate for what we've lost?
Yeah, I think I don't know. My opinion editorial on this is the first thing we need to do is realize that we too are part of the system, right? I mean, I think I hear a lot from physicians and even nurses that I work with that, well, it's this guy's fault or that gal's fault or the system, right? It's the system. And it's like, well, wait a minute. Like, I think we're part of that system. I think we used to have a voice in the system. I think we used to interact with the system differently than we do now, which is, at least in the US, is much more handed down from above with people far from the problem, with good intentions trying to solve our problems. But in reality, the problems have to be really resolved, at the grassroots on the ground floor and move their way up. So some of it's mindset from a leadership perspective. But the other thing I think is, and I think probably what you're seeing in the UK, I don't know the details around the unions and the striking and things like that, is a little bit of a need for some grassroots to say, hey, wait a minute, this really isn't working. And this is why my patient's existence and my existence is suffering, because we need to take back some of the things that are being part of that are part of the system, but that we potentially can have control over.
I hope you're enjoying the show. Please click subscribe so you'll be notified when new episodes become available. This podcast is part of my mission to help doctors create successful and meaningful careers. You can be part of that mission too by forwarding this show to one person who you think might benefit from listening. Thank you. Now on with the show.
I think for me, it can be overwhelming with the whole system kind of crashing down around you. But one of the things I've tried to do consciously as a clinician is to just go see the patient. I don't drag in the electronics. I don't drag in the computer. I walk in that exam room and close the door, and inside that room is me, the patient, the parent. There's no administrators. There's no EHR. There's no outside noise. It's like really trying to sit down, focus in on being the best clinician I can, which means listening and doing those kind of things. And that's added some longevity to my career, because certainly when you come out, it's pretty easy to go down what I call the rabbit hole of this is wrong and that is wrong and everything is wrong and the world is ending. And right, it's easy for us clinicians to kind of drag in there. And if we continue to put the patient at the center, and if we fight for the patient, I think we'll find ourselves, impacting the system far better than fighting for ourselves. But we need to speak up. We need to come together. We need to voice our concerns and our ideas and ways that we can turn around our own burnout and our own problems within the system. Right. Globally, it seems like everybody is struggling. This isn't a US problem or a UK problem. This seems to be everywhere. And so there's something that we're missing. And again, I think we've kind of lost sight of that patient-centered care and those relationships with the patient, and thought more about revenue or profit or systemization or assembly line or super specialization that is kind of impacting, I think, all of our happiness and our patient outcomes and our self-worth and what we're doing and our why of why we started this whole thing in the first place, right?
I'm interested in this blaming the system, and a term that I quite like is helplessness. You know, we're all helpless.
Yeah,
there's this system, and we are helpless in the
yeah.
face of the system. So and of course the reality is that, you know, we're not helpless at all. You know, there's lots of things. Maybe I can't single-handedly change the whole of NHS, but I can single-handedly change my environment around me, or at least give it some quite strong nudges. You know, if
Yeah.
but I'm interested in your, because you said that, you know, we say it's the system and the system isn't me, but you know what you're saying is that you and I are the system. Can you tell me a bit more about that?
Yeah, I think we're all part of this. I think the first, I don't know, isn't the first thing kind of saying you have a problem, right? Maybe I'm part of the problem, right? If you start there, then you might roll back. Okay, how do I treat the nurses? How do I treat my patients? How do I, what am I doing that could interact differently even within the system? Like I don't do all the click boxes in the EHR. I dictate my note. I do things consciously to ensure that the patient comes first, treating the patient comes first, and then work my way kind of backwards, as opposed to feeling like I need to dictate the perfect note or click all the perfect boxes or do all the perfect things, right? So sometimes there's a little bit of what I call disobedience, right? Because we've been trained in, hey, you got to do this and you got to do that and you got to do the next thing, and there's actually some room for us to be disobedient if we can put the patient first and put kind of that care first, right? There's some things that we are required to do that just aren't helpful or that we're asked to do perfectly that really the perfect isn't helpful to anyone, right? And I'm not saying cutting corners or workarounds. We get plenty of that, right? It's more about, in each step of the way, if you put the patient centered first, then I think we collectively, as how you and I, if I call you and say I've got a consult for you, how do you interact with that ER physician? Right? Are you grumpy? Are you mad at me? Are you yelling at me because I woke you up at 2 a.m? Or you're like, man, this guy's up working and trying to keep me asleep and doing his best, and he's at his wit's end, and he's stuck trying to figure out a complex problem, and he's calling me because I have that expertise, and so we're working together on it, as opposed to I've got this mindset that the ER is the worst, and they call me all the time, and they don't know anything, right? I mean, it goes back to some of the psyche, I think, and the things where we put the patient first and put each other first. I think we'd solve a lot of problems, right? I mean, if the ENT doc didn't see the ER doc as a nemesis, which becomes more and more of it, like, oh, you're making me work, you're making me get up. It's like, hey, we're here for each other. I think our whole system of how we interact with each other and our patients might change, right? If I consulted a surgeon, they come and said, hey, we saw Johnny, appreciate your perspective, but we think this, that'd be a heck of a lot more helpful than, I don't know why you called me, this is a nothing, right? Like demeaning the other physician or vice versa, which is a lot of what we face, in kind of the ER approach and vice versa, right? I'm sure we're not the nicest to folks either, but how we treat our patients, how we treat our other would be a great start to kind of reorganizing our system around taking care of each other, as opposed to we're kind of trained in being obedient and dominating and competing and doing those kind of behaviors that aren't helping any of us.
the 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 idea of being a little bit disobedient and doing what the patient needs rather than what what the hospital says you should be doing, or what your colleagues said you should be doing. Is that something that happens with seniority? I'm wondering how an intern would be able to do that. Is that something that you and I have the luxury of doing because we're a bit
Yeah,
old?
no, I think what we have to teach is kind of the congeniality of no, right? Like we never learn no in medicine, right? And when's the last time you said no? I mean, when I left the ER and I did pediatric sedation, where we helped kids lie still for MRIs and LPs and kind of mini anesthesia, essentially, because there was a gap there that we needed to fill, where kids were either getting pinned down or those kind of things. the main thing I had to teach the ER physicians is we had all the clinical skills, but we had to know when to say no. Like, no, it's not safe for us to do this, or no, this patient doesn't need this or doesn't need that, right? So it's pretty interesting because as I think about medical training, there's very little time where we say no, like no, like you know what I mean? It's all yes and yes sir and yes man and yes doctor, and so there is a little bit of time. I was just recently in a role where I was instructed that part of my job was to ensure that all the physicians typed on the EHR in front of the patients. Like there was no room from the higher ups that in order to drive our efficiency, everybody had to do their electronic medical record while they were seeing the patient. And that's where it's like, man, how do we not say no to that sometimes, right? How can you really mandate that down, and why collectively would we say, yeah, that's okay, when we all know that distracts us and it's not good experience for us, it's not good experience for the patient. So how do we stop that kind of train, right? So I think sometimes we've also lost the fact that doing less is sometimes better in medicine, right? We've kind of got this idea that whatever the patient wants we should give them, when in reality sometimes you got to say no and explain something to them, and they appreciate that, right? As opposed to just kind of taking on every whim and whimper. So there is a little bit of that, educated disobedience, and maybe we need to model it more for the interns and the residents, in the sense of no because I'm lazy, or no because I want to go home early, or no because I want more money, but no because it's not best for the patient, it's not best for this clinical interaction. It's not best for these things, where it's like we should push back a little bit on some of these things that are taking us away from better care.
And do we do that individually or do we do that as a profession?
Well, I don't think I think for any of these things that we don't start individually, we can never do it as a profession, right? I mean, it really has to come from us, right? So the way that I interact with the residents, I hope is seen to them as interactive. And I'm sure I have my bad days and whatnot, but I hope they never walk away from it like, well, I'm not going to present my case to that guy because he's an old grump, right? Or he's mad, or I'm not going to call that surgeon because he might throw something at me, right? So I think it does come down to, and I think it comes back to kind of the old school stuff we were talking about, where we had an hour lunch to get together in a medical staff lounge. Like I didn't know you. I would not only know your name, but I'd know you where you played golf, or what your hobbies were, or what your family was like. And so when we had those interactions in the ER or after hours, it wasn't like, who is this person calling me? It's, hey, this is my colleague, and I know he's not a bad guy, right? Or he's not an idiot, or right. We had more of that personal connection. And I think from our nursing staff to the frontline staff, sometimes we lose that, and we really it almost takes an extra effort now to get to know people a little bit. And those relationships are really important. And I can tell you, my satisfaction at work is highly dictated by how others treat me, right? When I call somebody and they're super nice, it's like, man, thanks so much. Like this just made my day, as opposed to when someone is giving me the same opinion, but in a different way. And I'm sure patients feel that, right? As we burn out, I'm sure we can deliver things very differently. So how do we get back to the mindset of, hey, you're the most important thing right now. I'm going to pay attention to you, listen to you, and we can have that dialogue, as opposed to I'm distracted, overwhelmed, burnout, and things like that. I think if we pick up some of those little fruits along the way, so to speak, I mean, if we pick up some of those things, we might be able to turn the tide a little bit on some of these things that we're waiting for others from the top down to change or intervene on.
So I really like, what you said is that in the past, it would probably be quite easy for you and I, or for physicians in a hospital, to have relationships, or in an area to have relationship, because everything was face to face, and and we probably all lived in the same area, and we all went to same schools, or our children went to same schools, we all played the same golf or tennis club or whatever. So it was very easy to get to know people as individuals.
Yeah.
Whereas the way that we work now, whether that's electronic stuff, shift system, the sheer size of the healthcare that we work in, is the reality is that those interpersonal connections, they do not happen automatically. And the key thing that you said is that we need to work at them. Yeah.
Yeah, no, I think absolutely. I mean, once, we used to send out flyers when they introduced a new staff member, used to talk about their hobbies, right? We used to get to know them. We'd call them, we'd have they'd be introduced to the medical staff. So we've kind of lost a lot of these things that seem superfluous and time wasters. But in reality, I kind of wonder, I kind of joke too, because, we certainly have a huge mental health crisis here. And I was like, man, what if we brought back family dinner? What if everybody in the family put their phones down, and maybe it's once a week, maybe it's twice a week, we all sat around and ate supper or dinner together? And how would the mental health crisis be impacted if families got to know each other and we weren't all doing 6 sports and 2 jobs and on the internet half the time? You know what I mean? Like, to me, there is a little opportunity for us to slow down before we speed up, or we're just moving so fast all the time. I think we're losing some of these really important pieces that don't pay us, they're lost leaders, they don't move the needle. Like, I can't see patients faster, but man, my satisfaction is waning, and my patients are not happy, and I'm not happy, and my nurses are leaving. If you have that team, you had that environment, you had that family feel, it was pretty nice back then, right? And it wasn't always about this great case or that great case. It's really like, hey, thanks for your help on that case. I really needed your help on that foreign body in the ear, and I couldn't get it, and the kid was screaming, and you're a peds ENT and you helped me out. That was cool, right? Like, I miss some of those things.
And I'm smiling because my hospital's organised a consultants dinner, and I'm really looking forward to it. And there's 1,000 consultants that work in my hospital, and of course then there's non-consultants as well. So I don't know how many people are going to go for dinner, but I'm looking forward to it because it's probably going to be, certainly, I mean, the first time in over 10 years
Yeah.
where anything like that has been
Yeah.
organized. Yeah. Whereas when I started, you know, Friday afternoon always used to be non-clinical. Nobody did clinical work apart from the emergency people on Friday afternoon, and and everybody went to the mess or wherever else, or educational activities or whatever it
Yeah.
was. But
Yeah.
you always saw people face to face, and you had coffee, and a lot of, certainly, I don't know about yours, but a lot of our meetings are all now online. So
Yeah.
you come online, you talk business, 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 and then you disappear. Whereas in the past you'd have gone online, then you would have had a lunch break and 2 tea breaks, and you chat, you
Yeah.
get to know people, which is all the stuff that you talked about. So that when you do then end up phoning each other at 2 o'clock in the morning or whatever it is, it's fine, because I remember like last month we chatted over coffee. You're a normal human being, so
Yeah.
who knew? Yeah. So and
Yeah, it's kind of like the social media, the bullying you've experienced, the bullying I've experienced. It's often distant, without a name, and or if it is a name, it's ego and pride, and you don't really understand, the pain and suffering you're inflicted on somebody because you don't have any attachment to them. Whereas if you have to see that person again, you might treat them differently, and you might receive it differently,
yeah.
right? As opposed to, well, that guy's just a jerk, right? So I do think we have to get back. I'm glad they're organizing some of those things, and there's subtle ways that really could help, that really could just be more than pushing around a cart of candy, which is typically what folks do in our hospital to build camaraderie. It's like, man, just cover the ER for 30 minutes. Let us all sit in a room and say hi to each other. It's like, that would be far more beneficial. But hopefully, to your question, I think you and I can start, and the next person can start when they have that same feeling from somebody else. And it's kind of that grassroots of, hey, let's try for a day to treat everybody like we want to be treated and see how it goes. Yeah.
One of the challenge with those social things that I'm finding is that let's sort of say, somebody organized, whether it's me or somebody else or whoever, somebody organizes something social, and people just don't turn up.
Yeah.
And I get that people are tired, they're burnt out, they've got lots of stuff on, and they kind of say, of everything that I need to do, I've got so much work to do. Why would I go and have lunch with Mick? Yeah, I have so many things to do. Having lunch with Mick is the last of my many things that I need to
Yeah.
do. So, what would you and I sort of have to say to somebody? Okay, I know you're busy, and I know you've got all of those things, but come and have lunch with me. So how do we persuade people?
Yeah, I think it's a good question. I mean, I think if you and I looked at it and went backwards and said, okay, here's all the things that I'm told I have to do, right? Maybe some of this is disobedience, right? These are all the things I'm told I have to do. But if I prioritize the things that were most important to me, what would I do? Right? Would I spend an hour on charts or would I go have lunch with you? Right? If you and I could create a relationship that then spawn more discussion around pediatric ENT and the ER working more closely together, that might pay off a lot more than doing my charts for an hour, right? And maybe I do those while I'm on shift or, I'm working at other times. But I think one of the challenges, and I think you and I mentioned this before we came on, like a lot of options is great, but a lot of options also is challenging. And right now we have so many distractions in our life and so many other things that we could be doing. I often wonder how many times each of us, myself included, really sit down and say, what's really important right now that I need to get done, or what's most important to make me happier, or how can I turn around my burnout or my depression or my anxiety? Is it working harder? Is it taking a hike, or is it getting to know my colleagues a little better? Or, you know, that's always a good question, right? Like I do think we've kind of kept busy and feel like the more busy we are, the more busy we can become, and the happier it is in distracting us from how unhappy we are until we're profoundly unhappy. Right? So,
Is that pausing, thinking what is it that really matters, and investing in the future, your future, my
yeah.
future, our patient's
Yeah,
future.
I'm a big college football fan. College football over here obviously is a different object than your football, but it's there's a coach that's famous over here called Lou Holtz, and his line is always, what's it take to win? And win for him is what's important now. So what's important at this very moment, whether we're taking care of patient, interacting with each other, or his great analogy is he's a high paid, successful football coach, but he was on a rafting trip and went out of the raft, whitewater rafting, and went underneath it. And he's like, what's important now? And it was getting out of underneath that raft, right? And I think as physicians, sometimes we're underneath that raft and we're still swimming and doing all those other things, as opposed to like, maybe we could just hop up and hang out maybe one of my buddies will pull me up and we can do this differently next time. But yeah, I think with our, as you age, you have to model some of that for the younger residents. We have to do a better job of that, for sure. But I'm hopeful that, individually, as we have more discussions about burnout and frustrations and the system, that we start to take some accountability ourselves, and some easy actions, some quick wins that we could easily do by just treating each other better, the nurses better, and the residents and our patients better. I think I come away much happier, with a good interaction than I do if somebody's, not nice. And hopefully it's not me being not nice, right?
Okay. I'll maybe bring us to a close, Mick, and maybe if I could ask you in relation to this topic, what would be your top tips then?
Yeah, I think the most important thing I'm trying to do, maybe personally, is listen, right? Like having interactions like this and not coming to you with, hey, this is how I think things should work. But maybe the first question should be, how do you think things should work, as we interact with folks? Or how could I be a better physician for you as a patient? How could I be a better physician for you as a nurse? Maybe if we slow down and kind of got a little more perspective from others on our own behaviors, maybe we could do that. So I'm hoping that we can kind of slow down, listen, but also take our accountability that, the system isn't some nebulous thing. We're all part of it. And we have our say in how we treat people and how we interact with each other.
Wonderful. That's a great tip. Thank you very much, Mick.
All right. Thanks for your time. Appreciate it.